Nerves of lower limb. Femoral nerve. Femoral nerve is the nerve of anterior compartment of thigh. Its cutaneous branch, the saphenous nerve, extends to the medial side of leg and medial border of foot till the ball of the B1G toe. Root value, dorsal division of ventral rami of L2, L3, L4 segments of spinal cord, see Figs 3.3 and 3.11. The course, it emerges at the lateral border of psoas major muscle in abdomen. It passes downwards between psoas major and iliacus muscles. The nerve enters the thigh behind the inguinal ligament, lateral to femoral sheath. It is not a content of femoral sheath as its formation is behirid fascia iliaca. Termination, it ends by dividing into two divisions 2.5 cm below the inguinal ligament. Both these divisions end in a number of branches. In between the two divisions, lateral circumflex femoral artery is present. Bronches, in abdomen, femoral nerve supplies iliacus muscle. Just above the inguinal ligament, it gives a branch to pectineus muscle, which passes behind the femoral sheath to reach the muscle. Its branches in the thigh are shown in table Al.1. Obturator nerve. Root value, obturator nerve is a branch of lumbar plexus. It arises from ventral division of ventral rami of L2, L3, L4 segments of spinal cord, see Fig 4.4. Beginning and course, it emerges on the medial border of psoas major muscle within the abdomen. It crosses the pelvic brim to run downwards and forwards on the lateral wall of pelvis to reach the upper part of obturator foramen. Termination, it ends by dividing into anterior and posterior divisions. In between the divisions, adductor brevis is seen. Anterior division, it passes downwards in front of obturator externus. Then it lies between pectineus and adductor longus anteriorly and adductor brevis posteriorly. It gives muscular, articular, and vascular branches. Posterior division, it pierces the obturator externus and passes behind adductor brevis and in front of adductor magnus. It also ends by giving muscular, articular, and vascular branches. Accessory obturator nerve, value. Ventral division of ventral rami of L3, L4 nerves. Course. Runs along medial border of psoas major, crosses superior ramus of pubis behind pectineus muscle. Branches, deep surface of pectineus, hip joint and communicating branch to anterior division of obturator nerve, see Fig 4.6. Superior gluteal nerve. Root value. L4, L5, S1. Course, enters the gluteal region through greater sciatic notch above piriformis muscle. Runs between gluteus medius and gluteus minimus to end in tensor fasciae lati, see Fig 5.14. Branches, it supplies gluteus medius, gluteus minimus, and tensor fasciae lati. Inferior gluteal nerve. Root value, L5, S1, S2. Course enters the gluteal region through greater sciatic notch below piriformis muscle, see Fig 5.14. Branches, it gives a number of branches to the gluteus maximus muscle only. It is the sole supply to the large anti-gravity, postural muscle with red fibers, responsible for extending the hip joint. Nerve to quadratus femoris. Root value, L4, L5, S1. Branches, it supplies quadratus femoris, inferior gemellus, and hip joint. Nerve to obturator internus. Root value, L5, S1, S2. Branches, it supplies obturator internus and superior gemellus. Sciatic nerve. Sciatic nerve is the thickest nerve of the body. It is the terminal branch of the lumbosacral plexus. Root value, ventral rami of L4, L5, S1, S2, S3. It consists of two parts, see Figs 5.6 and 5.14.
Stop.
medial part, its root value is ventral division of ventral rami of L4, L5, S1, S2, S3, segments of spinal cord, see Fig 7.6. Common peroneal part, its root value is dorsal division of ventral rami of L4, L5, S1, S2 segments of spinal cord. Course, sciatic nerve arises in the pelvis. Leaves the pelvis by passing through greater sciatic foramen below the piriformis to enter the gluteal region, see Fig 7.7. In the gluteal region, it lies deep to the gluteus maximus muscle, and crosses superior gemellus, obturator internus, inferior gemellus, quadratus femoris to enter the back of thigh. During its short course, it lies between ischial tuberosity and greater trochanter with the convexiety to the lateral side. It gives no branches in the gluteal region. In the back of thigh, it lies deep to long head of biceps femoris and superficial to adductor magnus, see Fig 7.z. Termination, it ends by dividing into its two terminal branches in the back of thigh. Bronchus, the branches of sciatic nerve are shown in Table Al.3. It lies superficial to the popliteal vessels. It continues in the back of leg beyond the distal border of popliteus muscles. In back of leg, the nerve descends as the neurovascular bundle with posterior tibial vessels. It lies superficial to tibialis posterior and deep to flexor digitorum longus. Lastly, it passes deep to the flexor retinaculum of ankle, ser Figs 9.2 and 9.7. Branches, its branches are shown in Table Al.4. Termination, the tibial nerve terminates by dividing into medial and lateral plantar nerves as it lies deep to the flexor retinaculum.
Don't stop. 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 Don't.
Common peroneal nerve. This is the smaller terminal branch of sciatic nerve. Its root value is dorsal division of ventral rami of L4, L5, S1, S2 segments of spinal cord. Beginning. It begins in the back of thigh as a smaller subdivision of the sciatic nerve. It lies in the upper lateral part of popliteal fossa, along the medial border of biceps femoris muscle. It turns around the lateral surface of fibula. Then it lies in the substance of peroneus longus muscle, see Fig 6.4. Branches, its branches are shown in Table Al.5. Termination, ends by dividing into two terminal branches, i.e. superficial peroneal and deep peroneal nerves, see Fig 8.9. Deep peroneal nerve. The deep peroneal nerve is the nerve of the anterior compartment of the leg and the dorsum of the foot. It corresponds to the posterior interosseous nerve of the forearm. This is one of the two terminal branches of the common peroneal nerve given off between the neck of the fibula and the peroneus longus muscle. Course, the deep peroneal nerve begins on the lateral side of the neck of fibula under cover of the upper fibers of peroneus longus. It enters the anterior compartment of leg by piercing the anterior intermuscular septum. It then pierces the extensor digitorum longus and comes to lie next to the anterior tibial vessels, see Fig 14.4. In the leg, it accompanies the anterior tibial artery and has similar relations. The nerve lies lateral to the artery in the upper and lower third of the leg, and anterior to the artery in the middle 1/3. The nerve ends on the dorsum of the foot, close to the ankle joint, by dividing into the lateral and medial terminal branches, see Fig 8.4. The lateral terminal branch turns laterally and ends in a pseudoganglion deep to the extensor digitorum brevis. Branches arise from the pseudoganglion and supply the extensor digitorum brevis and the tarsal joints. The medial terminal branch ends by supplying the skin adjoining the first interdigital cleft and the proximal joints of the big toe. Deep fibular nerve, muscular branches to the following muscles of the anterior compartment of the leg. These include Tibially anterior extensor halsis longus, extensor digitorum longus and peroneus turluus to the extensor digitorum brevis, on the dorsum of foot, is supplied by the lateral terminal branch of the deep peroneal nerve. Course and branches. The lateral terminal branch of the deep peroneal nerve ends by forming the dorsal digital nerves for the adjacent sides of the big toe and second toe, see Fig 8.2. Articular branches. 1. Angular branches. These are give to the articular joint. Tarsal joint. Tarsomtatarsal joint. Metatarsophalangeal joint of big toe. Superficial peroneal nerve. It is the smaller terminal branch of the common peroneal nerve, Ser Fig 8.9. Origin. It arises in the substance of peroneus longus muscle, lateral to the neck of fibula. Course. It descends in the lateral compartment of leg deep to peroneus longus. Then it lies between peroneus longus and peroneus brevis muscles and lastly between the peronei and extensor digitorum longus. It pierces the deep fascia in distal 1/3 of leg and descends to the dorsum of foot. Branches. It supplies both peroneus longus and peroneus brevis muscles. It gives cutaneous branches, see Fig 8.2, to most or the dorsum of foot including the digital branches to medial side of big toe, adjacent sides of second and third and fourth and fifth toes. The nail beds are not supplied as these are supplied by medial plantar for medial 3, 2 and bilateral plantar for 1 atira 1 LZZ toes. Adjacent sides of big and second toes are supplied by deep peroneal nerve. The medial border of foot is supplied by saphenous and lateral border by sural nerves. Plantar nerves. The medial and lateral plantar nerves are the terminal branches of the tibial nerve. These nerves begin deep to the flexor retinaculum. Terminal branch of tibial nerve. Its distribution is similar to median nerve of the hand. It lies between abductor hallucis and flexor digitorum brevis and ends by giving muscular, cutaneous, and articular branches, see Fig 10.4b. Bronchus. The branches of medial plantar nerve are shown in Table A 1.6. Lateral plantar nerve. It is the smaller terminal branch of tibial nerve, resembling the ulnar nerve of the hand in its distribution. It runs obliquely between the first and second layers of sole till the tuberosity of fifth metatarsal bone, where it divides into its superficial and deep branches, see Fig 10.6b. Branches. The structures supplied by the trunk, and its two branches are given in Table L.7. Femoral nerve supplying the quadriceps femoris through L2, L3, L4 segments of spinal cord is tested by doing the patellar jerk. The ligamentum patelli is hit by the hammer and the contraction of the quadriceps is felt with extension of knee, see Fig 3.30. Since obturator nerve supplies both the hip and knee joints, pain of one joint may be referred to the other joint. The paralysis of left superior gluteal nerve leads to paralysis of left gluteus medius and minimus muscle. During walking when the body is supported on left foot, the right unsupported side of the pelvis droops, causing inability to walk with right foot. This is called Posa-Fertrei-Gellenberg's test, Ser Fig 5.12, sleeping roof. Sometimes it happens that one is awake but the foot sleeps. Sciatic nerve lies on quadratus femoris and adductor magnus. Between the two muscles, the nerve lies on the hard femur. So the nerve gets pressed between the femur and the hard edge of table, chair, or bed. There is numbness of the lower limb till the foot is hit against the ground a few times. The sensations come back, see Fig 7.3. Injury. Injury to sciatic nerve leads to paralysis of hamstrings and all muscles of the leg and foot leading to foot drop, see Fig 7.11. Sciatica is the name given when there is radiating pain in the back of lower limb. It may be due to slip disc. Common peroneal nerve is the commonest nerve to be paralyzed. This is injured due to fracture of neck of fibula, lay the injury on the lateral side of knee joint or due to plaster on the leg. In the last case, the nerve gets compressed between hard plaster and neck of fibula. To prevent this, cotton must be placed on the upper lateral side of the leg, see Fig 8.9. The effects of injury are, motor loss, to dorsiflexors and evertors of foot. The typical position of the foot is foot drop, sensory loss is to the back of leg, lateral side of leg and most of dorsum of foot. Articular loss to the lateral side of knee joint. Paralysis of muscles of the anterior compartment of the leg results in loss of the power of dorsiflexion of the foot. As a result, the foot is plantar flexed. The condition is called as foot drop, SEC Fig 8.10. The motor and sensory loss of ears to the various nerves is shown in Table A 1.8. Thus most of the muscles of the lower limb are supplied by sciatic nerve except the adductors of thigh and extensors of knee joint. Arterial occlusive disease of the lower limb. Occlusive disease causes ischemia of the muscles of lower limb leading to cramp-like pain. The pain disappears with rest but comes back with activity. The condition is called intermittent claudication. Palpation of dorsalis pedis artery and posterior tibial artery gives information about peripheral arterial diseases, SRR Fig 8.11. Sympathetic innervation of the arteries, thoracic 10-12 and L3 segments provide sympathetic innervation to arteries of lower limb. Preganglionic fibers relay in the ganglia associated with these segments. Postganglionic fibers reach blood vessels via branches of lumbar and sacral plexuses. Femoral artery receives postgangliortic fibers from femoral and obturator nerves. Arteries of the leg receive postganglionic fibers via the tibial and common peroneal nerves. Lumbar sympathectomy for occlusive arterial disease. Sympathectomy, i.e. removal of L2 and L3 ganglia with intervening sympathetic trunk, is advised for this condition. This increases the collateral circulation. L1 ganglion is not removed as it is responsible for ejaculation. Blood supply to muscles of back of thigh reaches through a rich anastomosis, SRC Fig 7.14, formed by superior gluteal artery. Inferior gluteal artery. Branches of femoral circumflex arteries. Perforating arteries. Branches of popliteal artery. Excessive fluid from knee joint can be aspirated by putting in a needle in the joint cavity from its lateral side. Poischnian's heel, plantar aponeurosis, is attached to posterior tubercle of calcaneus and to all 5 digits. In plantar fasciitis, there is pain in the heel. Since policeman has to stand for long hours, they often suffer from it. Dipping gait, gluteus medius and gluteus minimus support the opposite side of the pelvis, when the foot is raised during walking. If these two muscles get paralyzed on right side, walking with left limb becomes difficult, as that limb dips down, while attempting to lift it. Walking with right leg is normal as this leg is supported by the normal left muscles, see Fig 5.12. Wenzersbottom, inflammation of the bursa over the ischial tuberosity. Since weavers have to sit for a long time, they suffer from it more often. Neuralgia paresthetica, lateral cutaneous nerve of thigh may pierce the inguinal ligament and it may get pressed and cause irritation over lateral side of upper thigh, see Fig 3.20. Housemaid knee, inflammation of prepatellar bursa, see Fig 3.6. It used to be common in housemaids as they had to sweep the floor with their knees bent acutely. Clergyman's knee, inflammation of subcutaneous infrapatellar bursa as he would sit for prayers with bent knees. Close pack position of ankle joint, dorsiflexed ankle joint when anterior wide trochlear area of talus fits tightly into posterior narrow articular area of lower end of tibia. Inversion injuries more common than Eserzian injuries. Inversion is accompanied by plantar flexion. During plantar flexion, the narrow posterior trochlear area of talus lies loosely in the anterior wide articular area of lower end of tibia. So inversion injuries are common. Fresher syndrome, overexertion of the muscles of anterior compartment of leg causes edema of leg as these are enclosed in tight compartment of deep fascia. This results in pain in the leg. Freshers are students who are just admitted in the colleges. They are competed to run by the senior students. So it occurs in them. Sites of intramuscular injections, in upper lateral quadrant of gluteal region into the gluteus medius. Also into the vastus lateralis, see Fig 5.9. Sites of pulse palpation in lower limb, femoral artery, popliteal artery, posterior tibial and dorsalis pedis arteries. Popliteal artery is used for auscultation to measure blood pressure in lower limb. Cut open venesection, a small cut given in great/long saphenous vein to insert a cannula for giving intravenous transfusions. Since position of this vein is constant, anterior to medial malleolus, the great saphenous vein is used for cut open. Tarsal tunnel syndrome, the syndrome occurs due to compression of tibial nerve within the fibro-osseous tunnel under the flexor retinaculum of ankle joint. This is associated with pain and paresthesia in the sole of the foot, often worse at night. Injury to medial meniscus, the medial meniscus is more vulnerable to injury than the lateral meniscus, because of its fixity to the capsule and tibial collateral ligament. The lateral meniscus is protected by the popliteus, which pulls it backwards so that it is not crushed between the articular surfaces, see Fig 2.18. Cruciate ligaments, tear of anterior cruciate ligament leads to abnormal anterior mobility, while tear of posterior ligament leads to abnormal posterior mobility of tibia, see Fig 12.15. Pes planus absence or collapse of the arches lead to FLST foot.